Hello everyone, I'm Dr. Ayush Pandey, and the topic for today's discussion, one of the important topics. And often, when you do practice in critical care settings or emergency setups, and especially during this winter season where these flare-ups and exacerbations are more common, and when we talk about how a normal asthma and COPD turn or the patient lands up into a critical care setup, and then, most of the, maybe at a very rural setup or maybe at a setup where the proper guidelines has not been yet followed. So treating asthma and COPD on the same lines has been followed, you'll see at majority of the settings. But the line of management changes because as you know that these both diseases have a different clinical entity, have a different clinical course. Everything is different and the line of management definitely is change or different when we're talking in terms of both the diseases. So coming to our first disease, our first topic for today's discussion, that is the asthma. And a brief, before dwelling into the management part of the exacerbations and the severity, let us look into a brief pathophysiology of the asthma so that you will be able to compare it with COPD, how this pathology is different. So, as you know, in Indian clinical care scenario, asthma is definitely regarded as an allergic disease, and the cells are involved in allergic response. So, mostly you see that if the parents or the grandparents have a history of asthma, even the child or the grandchildren, granddaughter also do suffer from asthma. So, genetic predisposition in one is one of the important factors when we talk about the asthma, and there is bronchial hyper-responsiveness. What do you mean by hyper-responsiveness? That is the bronchus, that is the airways, they become more hyperactive, or we can say that more of the inflammation has been set in. And this inflammation or hyper responsiveness of the bronchus is due to the inhaled stimuli and the cell based mediators. So, as we all know, that there are a minimum of 70 to 80 allergens in the atmosphere that we do encounter on day to day basis. Maybe we either inhale or maybe we either encounter, and there these allergen particles are not just particles which we do just inhale. We eat, they can be any plant based products, they can be food, they can be animal, cat, dander, they can be anything. But until and unless we know that we are being allergic to these substances, the proper evaluation and a workup has to be done, starting with all the allergic, panel, and then going ahead with skin prick testing and patch test. So until and unless you know, and you see that majority of the patients that they will come to you, they say that after eating milk or after drinking milk, after eating any peanut, they get that itchy response throughout the body, or they get all kind of exacerbation, shortness of breath triggers it. So maybe because of any dust, fumes, allergens, extremes of temperature, or any of the respiratory infections can be a predisposing cause. And because of this, the bronchus becomes hyper responsive. Because of this, if there is a patient is in exacerbation, there is bronchial constriction, there is narrowing of the bronchus, there is airflow limitation. And because of that airflow limitation, the patient gets breathlessness, the patient becomes dyspneic. But we'll be comparing, high degree of reversibility with bronchodilators. What do we mean? So whenever we perform a pulmonary function test like spirometry to a patient of asthma, and here is one of the clinching differentiating feature between the COPD and asthma is they are reversible with bronchodilator. So you give a bronchodilator, you perform a spirometry, and then you repeat the test again. So pre-bronchodilator one spirometry, post-bronchodilator one spirometry, you compare the PFT values, and there is the reversibility in the FEE1, that is forced expiratory volume in 1 second on the spirometry, and this is one of the clinching factors when talking in differentiation from COPD.